Today we are going to discuss on the topic osteosarcoma, osteo bone or osteotissue, sarcoma, malignant tumor of connective tissue. Overview, definition, epidemiology, pathogenesis, skeletal distribution, clinical presentation, evaluation, classification, investigations, treatment, and prognosis. What is osteosarcoma? Highly malignant bone tumor arising from primitive mesenchymal bone forming cells. Histologic hallmark is production of malignant osteoid, most common histological form of primary bone cancer, and it is the second most primary malignant bone tumor after multiple myeloma. Any bone can be involved, but the most common sites are distal femur, proximal tibia, proximal humerus. Most common metastasis is to lungs through bones bloodstream. Incidence more prevalence in males than females. Involves any age but highest occurrence in adolescence, that is 12 to 25 years. Skeletal distribution. Mainly the distal femur, uh, proximal tibia, proximal humerus, site of rapid bone growth, and the other regions. And the distribution is mainly major in the metaphyseal region than diaphyseal than epiphyseal region. Etiology, rapid bone growth. Adolescence growth occurred in the metaphyseal area near the growth plate and radiational exposure, most common cause of secondary forms and genetic predispositions, which are hereditary form of retinoblastoma, RB gene mutation, Lynch-Romani syndrome, P53 gene mutation, Rothman-Thompson syndrome, autosomal recessive inheritance, Paget disease of bone, mostly from secondary forms. Classification, primary or secondary. Primary osteosarcoma, mainly in the age group of 15 to 25 years. Low-grade intramedullary osteosarcoma, paraosteal osteosarcoma, periosteal osteosarcoma, high-grade surface osteosarcoma, telangiectatic osteosarcoma, and small cell osteosarcoma. Classification: secondary osteosarcomas. Osteosarcomas occurring at the site of other disease process, most commonly in age group greater than 50 years, mostly associated with pre-malignant conditions like Paget disease, previous radiational treatment, endochondromatosis, fibrous dysplasia, osteochondromas, and osteogenesis imperfecta. Histopathologic variants. Conventional type, osteoblastic, chondroblastic, and fibroblastic osteosarcoma, telangiectatic or osteolytic type osteosarcoma, small cell osteosarcoma, low-grade central osteosarcoma, periosteal osteosarcoma, paraosteal osteosarcoma, secondary osteosarcomas, and high-grade surface osteosarcoma, and extraskeletal osteosarcomas. Gross pathology, osteoblastic tumor, grayish white, hard and gritty feeling when cut, chondroid type, opalescent and bluish gray, fibroblastic type, typically fish flesh sarcomatous appearance, telangiectatic type, areas of tumor, necrosis, and blood-filled spaces. Histologic appearance, stroma, malignant connective tissue with anaplastic spindle cells in mesenchymal parenchyma, tumor cells surrounded by osteoid matrix, osteoblastic lot of new bone, fibroblast chondroid cartilaginous tissue. High-grade anaplastic spindle cells with large hypochromatic liquids can be seen here, and also osteoid bone production. New malignant bone production can be also seen in this diagram. Clinical presentation: pain, progressive pain, particularly with activity, swelling, palpable mass in the region of metaphysis, skin over the swelling, shiny with prominent veins, swelling may be warm and tender, decreased range of motion of the involved joint, lymphadenopathy, usually focal and regional lymph node involvement, respiratory findings, large state with lung metastasis, fever and night sweats are often rare. Uh, Investigations, mainly radiological examinations, which include plain X-rays, MRI, CT scan, and bone scans. Laboratory studies, serum alkaline phosphatase levels, biopsy, core biopsy, and FNAC, and angiogram can be done. Plain X-rays, you can see lytic lesions, sclerotic lesions, and mixed. It's the most common type can be seen in a plain X-ray. Plain X-ray. Irregular destruction in metaphysis, new bone formation, periosteal reaction, sun ray appearance or hair on end tumor growth is seen into the overlying soft tissue. Codman's triangle, area of subperiosteal new bone formation seen at the area of tumor post-cortex junction. This is the sunburst or sun ray appearance, and this is the Codman triangle where the periosteum is raised due to malignant bone formation. Codman triangle is a term used to describe the triangular area of subperiosteal bone that is created when a lesion upon a tumor raises the periosteum away from the bone. Here we can see the Codman's triangle and the sunray appearance. The Codman triangle, the periosteum is raised, and in the X-ray we can see a triangulated area. It is called as a Codman's triangle. MRI used to know the soft tissue extent. CT scans, not of much use in osteosarcoma. CT chest to detect lung metastasis. Laboratory studies, such as full blood count, ESR and CRP levels, uh, LDH levels, alkaline phosphatase levels, platelet count, electrolyte levels, liver function test, renal function test, and urine analysis can be done. Biopsy to confirm the diagnosis. Types: fine needle aspiration, core needle biopsy, open incisional biopsy. Anikin staging system. The staging system is typically depicted as follows. Stage 1, low-grade tumor, 1A, 1B. 1A is intracompartmental and 1B is extracompartmental. Stage 2, high-grade tumor, 2A and 2B. 2A is intracompartmental and 2B is extracompartmental. Stage 3, any tumors with evidence of metastasis. Differential diagnosis. Other such as giant cell tumors or osteoclastoma, chondrosarcoma, fibrosarcoma, aneurysmal bone cyst, Ewing sarcoma, osteoblastoma, metastasis, other metastasis, lymphoma, osteomyelitis, chondroblastoma, post-traumatic callus, and other variants. Telangiectatic osteosarcoma, painful radiological lytic masses, lesion in the metaphyseal portion of long bones. Most common site is the distal femur. Histology: bone-filled vascular spaces lined by osteoblast. Presence with local pain, soft tissue, masses, and fracture. Differential diagnosis can be aneurysmal bone cyst. Osteosarcoma arise from periosteum. Most common occurrence in adults. Most common site is posterior metaphysis of distal femur. Slow growing and late to metastase, and it has a better prognosis. Later ossified mass in center can be found. Periosteal osteosarcoma arise from diaphysis of long bones, most common femur and tibia. Presence with swelling and tenderness. 25% pathologically fractures can be seen, and X-ray shows sunburst or hair on end appearance. Histology, lobular and chondroblastic matrix, and has an intermediate prognosis. Prognostic factors: extent of disease. Patients with pulmonary, non-pulmonary, or skip metastasis have poor prognosis. Grade of the tumor. High-grade tumor have poor prognosis. Size of the primary lesion. Large-sized tumors have worse prognosis than small-sized tumors. Skeletal location. Proximal tumors do worse than distal tumors. Secondary osteosarcoma also has a poor prognosis. Treatment. Radiological staging, followed by biopsy to confirm the diagnosis, followed by pre-operative chemotherapy, followed by repeated radiological staging, access chemo response, finalize surgical treatment plan, followed by surgical resection with wide margin, followed by reconstruction using one of many techniques, and following with post-operative chemo based on pre-operative responses. Chemotherapy. The drug used most often to treat the sarcomas are methotrexate with leucovorin, folinic acid, doxorubicin, adriamycin, cisplatin or carboplatin, citrovorum factor, etoposide, and cyclophosphamide, actinomycin D, and bleomycin. Surgery. The main goal of surgery is to safely and completely remove the tumor. Historically, amputation was performed. Over the past few years, limb sparing procedures have become the standard mainly due to advances in chemotherapy and sophisticated imaging techniques. Limb salvage procedures now can provide rates of local control and long-term survival equal to amputation. Radiotherapy. Radiation therapy has no major role in osteosarcoma. Radiation therapy may be useful in some cases where the tumor cannot be completely removed by surgery. Example, in pelvic bones or in the bones of cases. Mega voltage of up to 6,000 to 8,000 rads can be used to treat in radiotherapy procedures. Immunotherapy. Portion of the tumor is implanted in sarcoma surviving patient and is removed after 14 days. The sensitized lymphocytes from the survivor are infused into the patient. These cells selectively kill the cancer cells in the bones. Follow-up and prognosis. Signs of recurrence, metastasis, and treatment. Related complications. Physical examinations, radiographs of the primary site, serial chest imaging, bone scans, and laboratory examinations should be followed up. In 50% cases with high-grade osteosarcoma, have some type of relapse in 5 months. If recurrence is detected, additional surgery, radical amputation, and chemotherapy may be warranted. 5 years survival rate is up to 5% to 23%. Thank you.